Today's episode is an interview with Jerilyn Arneson, a Revenue Integrity Pharmacist. Jerilyn and I met in April 2019 at the Medipreneurs Conference in Asheville, North Carolina. Medical care for many disease states is expensive. Jerilyn uses her voice to advocate for the financial best interests of her patients. She helps them access financial assistance so they can focus on battling their disease and winning back their health. If you've never heard of a Revenue Integrity Pharmacist, you need to listen to this episode. You're listening to the Pharmacist Voice podcast, a journey-style podcast about my career change from pharmacist to voice actor. I'm your host, Kim Newlove. I alternate solo shows and interview shows. The solo shows are about my career change, and the interview shows feature a variety of people who use their voices to advocate, educate, or entertain. I specialize in medical narration and e-learning. If you have a project in mind, contact me through my website, thepharmacistvoice.com. Thank you for joining me for episode 48. I'll tell you a little more about my guest, then we'll dive right into our interview. Jerilyn Arneson is a pharmacist with 22 years of experience in a variety of practice settings. She started as an Air Force pharmacist and spent most of her career working in military medicine. She's a Board Certified Oncology Pharmacist who transitioned to civilian healthcare in 2014. Currently, Jerilyn works for a healthcare organization in Virginia as a Revenue Integrity Pharmacist. She specializes in navigating medication access and reimbursement for outpatient infusion centers. In the last 6 years, Jerilyn has launched multiple medication assistance and financial navigation programs to assist cancer patients and other chronically ill patients with their treatment costs. She is also a certified Medicare benefits counselor and volunteers at Senior Services, where she helps patients select a Medicare plan that will cover their medical needs and assist them with complex problems, like denials of essential services. Without further ado, here's my conversation with Jerilyn Arneson. Hi, Jerilyn. Welcome to the Pharmacist Voice podcast. How are you?
I'm great. How are you, Kim?
Doing well. It's good to have you on the podcast today.
Yes, thank you. I appreciate it.
Jerilyn, you're a full-time Revenue Integrity Pharmacist. What is that and what do you do?
Well, a Revenue Integrity Pharmacist is someone who is evaluating everything that has to do with pharmacy cost and reimbursement, charge capture, making sure that we're charging appropriately, looking at reimbursement. Are we getting reimbursed appropriately? And also, we work on denials of high dollar drug claims. So I specialize mostly in outpatient infusion centers, and that's where the really high dollar drugs are at. And so one claim could be $20,000, $30,000, $40,000. And so if it denies for whatever reason, like we didn't get a prior authorization, or they feel like the insurance company needs more information about medical necessity, then I will write appeal letters for that as well. The last thing that it entails is I manage our patient assistance program for the pharmacy. So I get free drug copay assistance. I also sign patients up for Medicaid, different Medicare plans, the hospital's financial assistance program. So overall, I just help them get access to treatment.
That's awesome. I had never heard of that until you and I had a little conversation prior to this recording. It's very interesting, and I understand you focus on financial navigation. Is that right?
Yes. So there are a lot of places or a lot of hospitals where pharmacy owns what they call a medication assistance program, patient assistance program. I like to take it a step further and call it financial navigation, because I personally feel like the future of patient assistance lies in what's called insurance optimization. So if I have a patient without any insurance, I could continue to get free drug for that patient for years. But you have to ask yourself, why is the patient uninsured? Um, did they not qualify for Medicaid? Did anybody ever screen them for Medicaid? So maybe free drug isn't the answer, or free drug could be the answer until I could get the patient on Medicaid. But having Medicaid is going to benefit both the patient and also the healthcare system, because now you're going to be able to pay for those MRIs, labs, ED visits, surgeries. And these could all be things that the patient has been putting off because they didn't have insurance.
You described this sort of a role, that a revenue integrity pharmacist, as being the future of hospital pharmacy. Can you tell me why you said that?
Yeah, so traditionally, I think pharmacists have, at least in hospital pharmacies, we've been very wrapped up and focused on cost containment measures. And that's because usually your hospital chief financial officer is pushing down goals. They want you to decrease your drug spend by a certain percentage. But now, because the drugs are so expensive, so there's a new drug called Ocrevus for multiple sclerosis, and uh, one dose of that costs $16,000. So you can imagine, if you have an outpatient infusion center where you're infusing a high volume of these high dollar drugs, you want to make sure you're getting paid for those drugs. And that requires somebody to go in and look at the claims after they've been paid. And we need to make sure, number one, did it pay at all? Did it pay according to what our contract with that payer said? So did they underpay, or did they pay appropriately? So, and then that revenue will get routed back to the cost center for the pharmacy. And so the chief financial officer, not only is he wanting us to decrease our drug spend, they want to see that we're bringing in revenue as well. So pharmacy has always traditionally been looked at as kind of like a money drain on the hospital. But now, when we look at the reimbursement and we show we're getting the revenue, now we're not viewed that way, and we're more likely to get the resources that we need.
How did you learn what you needed to know to be able to do all this?
So I really fell into this by accident. I started my pharmacy career 22 years ago. I went right out of pharmacy school into the military, and I was an Air Force pharmacist for about 6 years. And then I got out and I worked as a civilian for the Air Force, for the Army. But in 2014, I decided to do something different and work for a civilian healthcare system. And I'm an oncology pharmacist, and my husband is in the Navy, and we moved frequently. And so there are times when I was in oncology, times when I was an inpatient, there's a time where I did outpatient. But when I went to this civilian healthcare system in 2014, I went back into oncology. And then in 2016, I became the pharmacy operations manager for the outpatient infusion centers. There were 5 of them in my area. And during that time, I staffed, even though I was a pharmacy manager, I still staffed. I noticed that there were frequent no-shows for chemo and other treatments for multiple sclerosis, Crohn's disease, whatever. And I just thought it was really odd. In the military, when I did oncology, we treated all age ranges, and that was not something that I really saw. I didn't see no-shows for chemotherapy unless the patient might have been neutropenic and hospitalized. So and this is just my personality, but I called the patients and I wanted to know what was going on. I thought maybe they were getting too nauseous from the chemo, and um, they felt like they couldn't handle the treatment anymore. Or I thought at the most, maybe they have transportation issues. But the story I kept hearing over and over again was they would go to their oncologist, get the diagnosis. No one ever talked finances with them. They would go to the infusion center. They would get 1 or 2 rounds of chemo, and then they would get a bill for 40, 50, $60,000. And
Wow.
yeah, they didn't want to leave their families with this debt. And so they were just self discontinuing their treatment. About the same time, again, this is all new to me. I'm familiar with drug reps as a pharmacist, but this new role for the pharmaceutical manufacturers called a field reimbursement manager. They started tagging along with the drug reps, and they were telling me about these medication assistance programs, either free drug or copay assistance. And so I just thought to myself, why are we so I know we have patients who are not getting treatment because they can't afford it. But on the other hand, I've got this field reimbursement manager telling me that no one's utilizing the programs. And so I thought, well, I don't know what I'm doing, but it can't hurt at this point. So I decided to give it a try. And so some of the field reimbursement managers even kind of coached me through the process. And it took me a good 8 months to learn how to do each part of patient assistance, whether it's free drug or copay assistance or tapping into foundations. Um, Part of the patient assistance is you also have to look at the claims after the patient is treated. So so this is very different than copay assistance when you go to Walgreens or Rite Aid and they have the copay cards. It doesn't work that way in a hospital. So we're billing for the chemo under the medical benefit. So what has to happen is after they're treated, we bill the insurance company. We have to wait for that payment. When I get that payment back, I need to make sure that the claim was paid appropriately because otherwise I can't get the copay assistance. So I learned really just by, you know, maybe some other people might say that I asked a lot of dumb questions. But I had people like a nurse auditor who was really great and explained things to me. And I kind of just picked up pieces as I went along. And, if it wasn't paid appropriately, I would say, well, how did you know that? Um, where can I find that? And so being able to read claims became really beneficial to me. And then the nurse auditors started to approach me about claims that were being denied. And I found out that if the insurance company denied the medication because it wasn't an FDA approved indication, that you can actually apply for free drug for those programs or for those patients. So I just became very proficient in reading hospital claims, specifically for infusion center claims. So that's kind of how I fell into it.
Okay. And when you were originally working at the hospital system, you were working in the inpatient pharmacy, right?
I was originally, and then they moved me to an off-site hospital outpatient infusion center. There was a pharmacy located inside of that cancer institute. And so I managed that pharmacy as well as the other pharmacies for the other infusion centers as well. So,
What you did, though, was you took on an additional role and then it developed to your only role, correct?
right. Well, yes and no. So I was I was the pharmacy operations manager for those infusion centers, and my side job was the patient assistance. And I never expected it to blow up the way that it did. Um, it was so eye-opening to see the number of patients that needed assistance. And these patients were just showing up to the infusion center hoping that they weren't going to get turned away for treatment. And so as I started identifying more and more patients, I was overwhelmed. And so I had to ask for additional help. And then obviously it benefits the patient, but it also benefits the organization, because now if I get free drug, that patient is going to get the drug whether they pay for it or not. And so now I'm reducing our bad debt. I'm reducing our drug spend. Um, when you get copay assistance, it's basically like getting cash. It's basically like getting free cash, because some patients who have a commercial plan might have $1,000 coinsurance every 3 weeks with their chemotherapy. So for those patients, you could apply for copay assistance for that.
Jerilyn, I get the sense that you've had some non-traditional pharmacy practice opportunities, starting with the Air Force, correct?
Right.
And then moving on to working as a civilian with the Air Force and then the
Hmm.
Army, and then you're out working in this civilian hospital. Is that the same hospital that you're working with now, or have you changed jobs yet again?
So yes, I've changed jobs. Now I'm at a small independent community hospital, and um, you're right in that the majority of my career has been spent doing very non-traditional things in pharmacy, starting with the military, and I really enjoyed. I feel like it's the best decision that I could have made at that time. I was really unsure about what I wanted to do after pharmacy school. I had interviewed at ASHP for residencies and just thought, oh, I can't do another year of like PharmD rotations. So I had a professor who was he was a retired Korean War veteran. And so we met, and he said, I feel like you need some structure in your life, and the Air Force, I think, would be a good match for you. And because I didn't know what I wanted to do, I was like, yeah, okay. I wanted to get out of the Midwest. I wanted to travel. And so I went down to Lackland Air Force Base in Texas. That was my first duty assignment. And I was thrown into oncology with no background training, and I had to learn it really fast. Um, and so I think I said before, like, because my husband is in the Navy, I'm in and out of oncology and switching jobs and switching roles. But you're right in that I always do find myself in a very non-traditional setting.
Has there been any formal training to do this revenue integrity pharmacist role that you're in right now?
No, it's a relatively new role for pharmacy overall. I think some of the larger health systems will have a pharmacy business manager, and that person usually has an MBA or an MHA. But now we're starting to see that pharmacists they can learn the financial side. ASHP does have a revenue cycle management certificate that you can do online, and I think it's 20 hours.
Do you recommend that for this
I
type of
do.
work? Yeah.
I do. I took it as soon as it was released, and that was, I want to say, maybe April or so. And so I had a lot of knowledge about the revenue cycle up until that point, but I took that course and it really filled in the gaps for me. Um, Questions that I had that I was going to have to go research myself, I found in the course. So I definitely would recommend it if you just want to know where to get started in revenue integrity.
There's a lot of pharmacists right now looking to do something else, something
Hmm.
non-traditional. Not only do you have that oncology background, which is different, but then you've got this revenue integrity pharmacist role that you can suggest to other people if they're interested in this type of work. What kind of pharmacist would enjoy this sort of work?
I personally think you have to have a curious mind. You have to be able to look at something and identify something isn't right. I don't know what that is yet, but I'm going to investigate it. So, the nurse, I work very closely with the revenue integrity nurse auditors. So they kind of do the same thing, but for supplies, and they're looking at surgeries, whereas I'm looking at infusion center and I'm looking at pharmacy. And I'll give you an example of something that I caught recently, and this is exactly why you need a revenue integrity pharmacist. So every day I run something called the DTAR, which is the daily transaction audit report. And there might be 6,800 line items. This is everything, that was
Wow.
charged over the last 24 hours. Obviously, I can't look through every one of those. So what I'm going to do is I'm going to look for outliers. So I would filter it and look at the cheapest, and then I would filter it and look at the most expensive and try to see, does that make sense? Well, what I found was we were charging 5 cents for 2 bags of oxytocin, 20 units, and 1,000 ml. And I thought, how did that happen? Why is that happening? Because it was happening on 15 different patients. So it wasn't just a glitch on one patient. And so I inquired with our pharmacy IT team, like, why do you think this is happening? And it ended up that we were charging, we should have been charging so many dollars or cents per ml, and we were charging 1 cent per bag. So it's just a box that didn't get checked somewhere along the line. And then looking back, we find that this has been happening since 2018. So the charge for 2 bags of oxytocin should have been $97.50. So if you think about that, and my pharmacy director will get a revenue and expense report. And if the revenue is down, this could be one of the reasons that the revenue is down, because we have a large labor and delivery service.
Hmm.
So these are the kind of things that you're finding. Um, and that's why I say I don't feel like it takes any formal training. You just have to be willing to ask questions, and because it's like a bad Sudoku puzzle, is what I always say. Like, as the other initiative that I work on a lot is the denials. So I write a lot of appeal letters. Sometimes I don't even know why it's denied. I'll just get an email from a nurse auditor or someone in the billing office. And what's really funny is the revenue cycle, they communicate very differently than the pharmacy. So when I'm talking to you as a pharmacist and I want to relay something to you, I'm going to use usually the patient's name and date of birth, right? So in the revenue cycle, they communicate via account number. So the patient's name is never even mentioned. It's
I'm
just
used
the
to
account.
MRN numbers. Do
Right.
they still use those?
They do. They do. So, and that's something that the clinical people would use. But revenue cycle, they go by the account number.
Okay.
And so they'll say this Remicade claim denied due to lack of medical necessity. And here's the account number, and they give me nothing else. And so it's my job to find out what is it that they're looking for. What clinical information did they need? What requirements are we not fulfilling in order to get paid for this treatment? So it's like a lot of investigation work.
Do you notice patterns? And then there's often similar situations among a number of different patients with different account numbers and all that.
Yes. So the one thing is the payers including Medicare, whether it's a commercial payer or Medicare, they're very clear in their guidelines. They publish policies all the time. Um, and and it will tell you in that policy what they're going to cover and what they're not going to cover. So I would say part of the revenue integrity role is keeping up to date with those payer changes. So I would, like, let's say they denied this Remicade. I'm going to see, okay, what is the ICD-10 code that they filed this claim under? Um, are they using it for an FDA-approved indication? So for the infliximab or the Remicade, for example, um, they're starting to look at Remicade levels, antigens that are developing due to Remicade. The clinical criteria is starting to change, but it hasn't changed across all payers yet. So there are a lot of times where the physician has actually done the proper tests that are needed, but he didn't include them in his notes. And so now I have to reach out to the physician and say, can you please addend your note and state what the levels were? And then I can resubmit the claim after that.
Well, that sounds like it could have a happy ending. Once the proper information's there, the hospital can get paid, right?
Right. So I will say it's very satisfying because you spend a lot of time when you're writing an appeal letter. You spend a lot of time reviewing clinical documentation, and I'll say I've learned way more about Crohn's and ulcerative colitis than I ever wanted to know. And these patients really suffer, is what I've learned. But you have to then tell the patient's story and how they progressed in their disease and why this drug is appropriate. Here's the documentation that was left off. And so when it comes back paid, you're like, yes, that's so satisfying because your work isn't done in vain. Um, but the appeal letters that the insurance companies are looking for are now require so much clinical detail that pharmacists make the perfect fit to write these letters.
Ooh.
So, they could use nurses, but when it's drug specific, I feel like pharmacists are the experts.
Since you're on the topic of how it feels to have that win, you win the appeal and somebody gets their medication paid for and the hospital doesn't lose money. That's a win-win. The patient gets their treatment. I wanted to know, is it okay to ask you to share an example of when you helped someone navigate a patient assistance program and get access to treatment instead of canceling those appointments and staying sick and not knowing how to get financial assistance? Can you share a success story?
Yes, I've got a lot of success stories, and I want to say this. It's not. I don't consider myself to be super smart that I figured out this pattern kind of identifying patients in need and applying to the programs. What I think it requires is you to be willing to go the extra step for the patient. And you'd be surprised at the number of people who won't do that, unfortunately. But when I first got to the hospital that I'm at right now, there's a patient who was on an off-label dose of a GI drug. And just from doing patient assistance at my previous organization, the first thing I looked at when I saw this dose is I thought, I bet you she's in a mound of debt. So I looked at her account. Sure enough, she was 50,000 plus in debt to the hospital.
Wow.
So I met with her, and first I called her and introduced myself, and she said yes, she had this pile of bills. She was so overwhelmed by the bills that she just put them in a drawer and closed the drawer.
Mm.
And I said, okay, bring it all in. Bring it all in. Let's look at it. So what I did was I thought, okay, what is the best course of action for this patient? If I'm able to get the patient the financial assistance that they need, it doesn't just benefit the patient, it benefits the organization as well. But I want it to benefit the patient first. So the very first thing I did was I applied for free drug based on that off-label dose, and manufacturers will give you free drug for that. So we were taking care of her bills going forward at that point. When you fill out these applications, they ask you for income data and possibly a disability statement or a disability award letter. And when she showed me her income, she was making $8,800 a year.
Oh, boy.
And she had Crohn's disease. She was having 10 to 12 bowel movements a day. So she was never really able to keep a job. And she's over the age of 65, so she had Medicare. But people need to keep in mind that when you're the working poor, you turn into the elderly poor. And, I thought, how is this woman living off of $8,800 a year? I have no idea. So then I thought, okay, well, she's not on disability, but why does she not have Medicaid? She has this really crappy Medicare Advantage plan, and she owes like $6,700 out of pocket every year. That's where it's capped. But why is she not signed up for Medicaid? So here's where the insurance optimization comes in. So I I signed her up for Medicaid, and any pharmacist any pharmacist can do that. You can be a representative for the patient and sign them up for Medicaid.
I have never done that personally, signed somebody up
Yeah,
for Medicaid, but I I'm glad that you brought that up as an option. I'd like to hear more about that.
she was the first patient that I signed up for Medicaid, but it's a long application process, but you can do it through the Medicaid website for your state. And then once you submit the application, the patient is assigned a caseworker through Medicaid. And then that patient can then communicate with the caseworker, getting them the documentation that they need and whatnot. So she was approved for Medicaid within 90 days, which is pretty good. And so what that did was then allow her to go get the other treatments that she needed. She had some dental issues that she couldn't take care of. Um, she needed to go in and get another CT scan, and she felt like she couldn't afford it. And so once we got her on Medicaid, that $6,700 out of pocket max from Medicare, that went away. So now everything is covered at 100%. The other great thing is that Medicaid will pick up your Medicare Part B premium, which is, I think, this year $144 a month. So she got that $144 a month, added back into her disability checks. So she got that extra money. But when you're signing them up for Medicaid, you have the option of also signing them up for SNAP or food stamp benefits, heating and cooling assistance, transportation, and literally to apply for those is clicking a box.
Mm.
And they use all of the same financial information to determine whether they're eligible for those programs. So, I felt like, well, we have a Medicaid vendor, but they only work with uninsured patients. So, what happens to all these elderly poor patients? And so, those are the patients that I traditionally will stop and sign up for Medicaid.
This is not something that you do outside of your role as a hospital pharmacist, right? This is part of your job
Right,
that you get to do that.
right. So, originally, when I started working at this hospital, they just called me like a financial navigator. I was a financial navigator pharmacist. And so, yes, so I got paid by the hospital to do this. And then after, the patient assistance program kind of got off the ground, then they gave me the official title of Revenue Integrity Pharmacist. So that's kind of how that transpired. But so to go back to the patient, so I got her Part B premiums paid for. She was eligible for she was eligible for everything because she only made $8,800 a year. And the last thing I did was I signed her up for our hospital financial assistance program. A lot of people who work in the hospital aren't even aware that every hospital has a financial assistance program. It just differs by the level of generosity, basically. Um, and so in this particular case, because no one had made her aware that there's a hospital financial assistance program, I was able to request an exception be made and for her previous balance to be written off by the hospital. And they did. And
Awesome.
yeah, so now the patient doesn't have to worry about debt going forward. And now that debt that was hanging over her head that she said was, it was causing so much stress that she was just, she couldn't even deal with it. Um, that's gone. And, she was just so overwhelmingly appreciative that somebody stopped and took the time to help her because this is not something that can be navigated by the patient. It is just too complex. The United States healthcare system is too complex. It was difficult for me to navigate, you know. So,
I
you know,
wouldn't know where to start, but the big thing is she got the financial assistance she needed and the treatment.
right.
It sounds like she almost got to start off with a clean slate, wouldn't you say?
Yes, yes. And and I review her claims on a monthly basis, and I love to see that there's zero balance.
Way to
Always
go.
a zero balance. Yeah. So, it's and now she calls me her guardian angel. And it's sad because I wish there were more people who would be willing to take the time to do that for a patient. Because I'll just kind of relate to my own background story. Is that my dad was an alcoholic and a compulsive gambler when I was growing up, and he was in and out of rehab frequently. And there's 4 kids in my family, and I remember my dad being in rehab and my mom sitting at the kitchen table at night crying with the checkbook, trying to figure out how she was going to take care of the bills and feed us and all of this kind of stuff. And out of nowhere one day, he had already been admitted a couple of times, but out of nowhere, someone, I think it was a social worker, showed up and signed us up for Medicaid. And it changed our lives. Like now we didn't have to spend the money on medical bills and go to the food pantry. We could now go and purchase our food and clothing and other things that we needed. So I feel like that experience, I know what it's like to be poor, and I know what it's like to feel the stress of not having any money and how are you going to pay for this and that. And so I feel like this is my way of being able to pay it forward.
That is awesome that you have the skills, the skill set. You are this non-traditional pharmacist who recognizes patterns and has this background of military service. And I know you've got that sense of duty.
Yes.
And when you see something that you relate to, which is what you just said, you relate to people that need help. You
Right.
accept the challenge, you hear the call to
Right.
serve,
Right.
and you do it. And if you don't mind, I'd like to transition to the nonprofit that you're part of right
Oh,
now.
yeah.
And that'd be a great time to talk about that.
Yeah, and I'll say one little snippet about the military. If there are any young pharmacists out there who aren't sure what to do, the military is a great place to start your career. It teaches you that you're not allowed to say that's not my job. Everything is your job. And that's one thing I hear from a lot of pharmacists is that's not my job. Well, okay, so whose job is it? It's got to be somebody's job. Why, if I have the ability to do it, I'll make it my job. So, I feel very grateful for that experience. But anyway, yes. So, me and 4 other ladies who kind of do the financial navigation or patient assistance like I do. We formed a nonprofit called the National Association of Medication Access and Patient Advocacy. I know it's a very long title, but the acronym is NAMAPA. And so what we're doing is we are providing resources and tools to teach other, I'm going to just refer to them as advocates because they can have various titles and do the same job, but we're all basically focused on making sure the patient has access to treatment. And so we're there's a webinar by them going on right now about how to re-enroll patients for the next year. So we're tackling these topics. I'll be providing content around Medicare because I'm a certified Medicare benefits counselor as well. And so we want to encourage more people to get into this field. And I think we just started, and there'll be more resources to come. But it's also there will be a forum where you can come and ask questions about difficult patients. And I know through LinkedIn, a lot of people have reached out to me to ask me how do you do what you do? Like how do you know how do you identify the patients? So there are people who are trying to get these programs off the ground. And to me, there's no dumb question because I didn't know what I was talking about. And we want to provide that kind of open forum and freedom to ask questions without feeling dumb. Go to namapa.org, and there's a couple webinars up there already, a few resource guides, but there will definitely be more to come by the end of the year.
Good. I'll put a link to that in the show notes so anybody that wants to explore this as a potential opportunity, they can check it out.
Yeah, that'd be great.
This would be an opportunity for a pharmacist to create a position in a hospital, correct?
Absolutely. Absolutely. What happens right now in a lot of hospital pharmacies is left over from kind of the old school way. It wasn't patient assistance. It's called drug recovery through your wholesaler. So like through AmerisourceBergen or Cardinal, they would recover free drug only for your uninsured patients only. And even then, they really didn't do a great job. I say that because, there's kind of a conflict of interest because they got paid a contingency fee, so they're going to go after the most expensive drugs and leaving the patients with smaller balances behind. Hospitals are starting to internalize this process, and they are starting to cut their contracts with these wholesaler companies. Yeah, this is absolutely the time. And so my next non-traditional role that I'll be going into is I'm going to be working for Atlas Health, which is a company that has software for patient assistance. And I get asked to do a lot of demos for free, of course, and so I don't do many demos anymore. But I had a few email exchanges with the CEO of this company, and I thought, oh, they really take the same approach that I do to patient assistance. And so I demoed the software, and it was amazing. There are about 4 other competitor software out there, but none of them have included Medicaid and the hospital's financial assistance program into the platform. So, like I was saying earlier, if I have an uninsured patient, it's going to integrate with whatever your electronic health care record is. But when it pulls that patient information and it sees that the patient is uninsured, it's going to pull up a list of all the available programs for that patient. With Atlas, if they're uninsured, the number one thing that's going to show up is Medicaid. And so that is exactly the way I approach financial navigation, patient assistance. I want to get them insured. Now, if they make too much money for Medicaid, then I'm going to go down to the free drug programs. So it almost, in a sense, it walks you through the process. So if you don't know where to get started, you don't know how to identify patients, this software would be, of great value to you. I know, it's tough to get your hospital to purchase software from a third-party vendor, but the other thing that I really liked about Atlas is that they will do a free return on an investment evaluation for you. So they're going to look at all of the missed opportunities for where you could have gotten free drug or copay assistance and will total up what you've basically left on the table. And whatever you've left on the table is 10 times more than what you're going to pay for the Atlas software. This is a mutually beneficial relationship where if I get the patient assistance, it's going to benefit the organization. So I think my approach and Atlas's approach is that we put the patient first. We want to do the right thing for the patient first. It's still going to benefit the organization. It just may not benefit just the pharmacy by getting free drug. If I get them on Medicaid, it's going to benefit the entire organization as a whole and the patient. So, it just kind of was by luck that I found a software company where my values and mission were aligned with theirs. So, so what I'll be doing is I'll be implementing this software in different hospitals, and then I'll be training advocates to do this work. So I'll basically be teaching them my workflow and using the Atlas software. So,
Jerilyn, are you basically going to be helping them use software to do the exact job that you do now? Is that kind of what you're doing?
So what I'll be doing with Atlas is I'll be implementing the software in various hospitals. And then I'll be teaching the advocates not only how to use the software, but kind of my approach to patient assistance and financial navigation. So the software doesn't necessarily replace me or replace the advocate. It allows you to extend your reach, and reach more patients. You can identify. So if you don't have to manually go through a schedule or a spreadsheet looking for patients, and you have software to identify it for you, that's time saved that I can now go and help other patients. So, what I want to say is I really love my job as a revenue integrity pharmacist right now at the hospital I'm at. I like the hospital. It was a very difficult decision for me to make, but I had to look at it this way. Like, if I stay at the hospital and I do my revenue integrity initiatives and I'm trying to manage the patient assistance program on the side, I can maybe reach 40 or 50 patients. Or I can go to Atlas and I can train 40 or 50 advocates who will then go on to help multiple patients. And so I can make a bigger impact that way.
I like how you're looking at that.
Yeah, that's how I had to think about it.
As we wrap this up, is there anything else you want to share?
Okay, yeah. So I would like to wrap up, by reiterating, going to the NMAPA website, so namapa.org, and looking for resources there. You can personally reach out to me on LinkedIn. I've made a lot of connections that way. Um, I am probably the worst consultant on the planet because, when people want to know how to do this work, it's hard for me to say, well, I'm not going to give you the information unless you pay me. So a lot of people have reached out to me on LinkedIn, and I try to help them establish their program when I can. The other thing is there's going to be a conference in May of next year. Hopefully, we'll see what happens with COVID, but it's called the Healthcare Advocate Summit, and it's in Galveston, Texas. It's basically for anyone who is currently or wants to navigate what we call navigating medication access and reimbursement. So, so that conference again is in Galveston, Texas, and I think the website for that is advocatesummit.com. And then finally, I would go to Atlas Health, to the website, and I don't have the link off the top of my head, but I think it's going to show up on your website, correct?
I'm going to put it in the show notes.
Okay,
So
got
we'll
it.
work on that
Okay.
together afterwards.
Okay, perfect. So I would encourage you, if you want to make an impact on someone's life, this is, as pharmacists, you have to want that at some level, or you wouldn't go into this profession. So, but if you truly want to have an impact, you feel like, you're at Walgreens, or you're working in a hospital pharmacy and your job has just become mundane and you've become detached from the patient and you want some sense of mission, this would be the job for you, because there's just such a need for it.
Awesome. Well, thank you so much for being on the Pharmacist Voice podcast and telling everybody about Revenue Integrity Pharmacist.
Well, thanks for having me. I enjoyed it. It was great.
All right. Take care, Jerilyn.
Thanks. Bye.
Thank you for joining me for episode 48 of the Pharmacist Voice podcast. Visit thepharmacistvoice.com to subscribe and read the show notes.